Yeah. So, when I got this topic, the bilateral femur fractures, if you see, it's one of those topics in the whole symposium which we're doing, in which we are actually have to see the larger picture here. It's not only about a femur fracture; it's about how the person's had a large, high intensity trauma, and he suffers a bilateral sharp femur. So this is a very, we get a lot of these patients, and our most of our emphasis is on basically how we approach these patients and how we stabilize them, and when do we choose to do the surgery. Shaft of femur, everyone knows, just nail it, and that's how it is. But I'm going to go a little beyond what the X-ray shows and what should be done here. So just give you an example. If you have a 22-year-old male who comes to you a road traffic accident and he presents to you after 4 hours, and his limbs are swollen and bilaterally deformed. So I ask my residents probably, well, what protocols will you follow? And ATLS is something which we don't do often. But if you are a good setup and if you have a good backup with anesthetists and all coming into the emergency, this is something which you see. On inspection, these are high intensity traumas, and you get a lot of blood loss. And blood loss in a one single sharp femur is about a liter. And if you have a bilateral sharp femur, you can be seeing something around 2.5 liters. That's so these patients have to be brought in and resuscitated very fast and recognized if they are dipping well. From the primary survey, what we need to understand with these patients is that they, as soon as possible, we should be able to maintain the vital signs. You should get the heart rate below 100, the systolic more than 100, and diastolic more than 70. If you're able to maintain this, get good temperature there, and also get adequate urine output, we are going towards a surgical management of these patients and maybe an early total care. Radiologically, it's very easy. It's very important, like Sir just said, it's very important and it's missed. I don't know exact frequency, maybe up to 5% in our hospital. We still miss neck of femur fractures, and this could be due to patient has some trauma in the pelvis or had some open fractures which was missed. But it's important to get these X-rays when you are getting an bilateral sharp femur fractures. So this is something which we don't talk about as orthopedic surgeons, but it's very important, and I would like to put emphasis on this. Besides all the basic tests which you guys get done, you have to see the lactate levels, which should be less than minus 2.5. Very, very important here. If you see a lactate level more than 5, the 28-day mortality goes up like 6-fold here. So, and all second thing is the base deficit. You have to maintain the base deficit between -2 and +2. Interlocking IL-6 levels, we routinely get them done when we see these polytrauma patients or both side bilateral sharp femur fractures. You want to maintain less than 500, and also the gastric mucosal pH should be more than 7.3. So these are only things which are, like I'm saying, these are patients which you have to see and make sure they don't go into any kind of shock. Compensated shock, not a lot of people talk about it, but it's very commonly missed. There's a normotensive patient gets tachycardia without fever, and patient may have a cool extremities and maybe having going into a shock. Like management for all femur fractures, even when it comes bilaterally, you can try, if you don't have these skeletal tractions, skin traction you can do good if the patient is going to be taken up for surgery within 24 hours. Skeletal, we all know, I'm not going to talk about it, but skeletal traction is also a part of damage control orthopedics. Then some part of these critically injured or borderline patients, they may not tolerate. Something like patient is getting a lactate more than 5, interleukin-6 more than 500. This patient has a concomitant chest injury or a bladder injury or something. Then, and plus the patient's looking at about 2.5 to 3 meters loss, we need to maybe think about taking the patient towards a damage control orthopedics. This is spoken a lot, and we always tell our residents that when do you choose the endpoint of resuscitation, and when do you think that everything's fine? Normally, everyone says that when the patient is having a good oxygen, there is hemoglobin is 9, heart rate, blood pressure is fine, but they are not actually the main reasons which can say endpoint resuscitation. So you have to have a continuous level. You have to check, and lactate and base deficits are two important things that we can find out if the patient is going through a normal intensive and getting resuscitated. These algorithm for ETC versus DCO, you all must be knowing it. So the idea is, like I'm telling you, if you see a patient who comes through the bilateral sharp femur fracture and your patient is lactate and is hypertensive and all that, This is when we decide, this is within 24 hours and maybe up to 72 hours when you can decide if you want to go in for early surgery or damage control orthopedics. We'll discuss this after the talk, but this is a ongoing discussion every day and happens patient to patient. External fixation is also a type of DCO. There are some patients who require immediate surgery. They need to be taken up for surgery, like for a subdural hematoma, or the patient needs a liver injury repair or something. Or if the patient is going to be shifted to the ICU, we have a minor operation theater which we right next to the emergency, and the patient just under a mask, we go in and just put modular fixators both sides, and we stabilize the patient. We don't care if the bones are touching or not, but we just go in and do this. And we do this quite often. Up to about 30% of the patients who come to us, we do this for them. Plating is, this is I've just got for theoretical reasons. There are some patients, again, when you don't have a C-arm, if the patient is going through a surgery for a head injury or a chest injury, and the patient is lying down, you can go ahead and do a plating. For femur fracture management, we all know that the gold standard is antegrade nailing, and it's always helped. And if you do this within 24 hours, you can really save lives, and the mortality morbidity goes down. Retrograde intermal nailing, this is another controversial topic, and I would like my seniors to talk about it. But this is something which we do also do, and this is besides being obese and everything. But if you are trying to do retrograde nailing, it is a good option when the patient is in one position and you try to put them on a table and you do it and it's faster than doing antegrade nailing on for bilateral sharp femur fractures. So basically, if you see these bilateral sharp femur fractures, we try to basically choose the less comminuted fracture we nail first, and then with that we can get a good length and idea about how much we have to nail the other side. So this is when we do it in one sitting. Antegrade versus retrograde nailing, there are many studies, Rishi and Ostrom are the famous ones which have done it. I mean, they're about, we can agree to disagree, but there are different union rates and knee issues and hip issues on both sides. Reaming, like we all discussed, and a lot of we discussed about reaming, when it should be done, when it shouldn't be done. In tibia, we know that. In femur, especially when it's bilateral, there is advantages of reaming and disadvantages also. But now more and more data is coming out that it's more on the safer side. I mean, we all know there's a big study by Canadian Orthopedic Trauma Society, and they said there's 4.5 times greater unreamed femoral nail. And Reaming and Bhandari et al., who does a lot of meta-analysis, has said that ream nailing significantly reduces rate of non-union and implant failure compared to unreamed nailing. But when it comes to multiple injured patients, suppose the patient has an ISS of 18 or higher, so we have to early stabilize these patients. And if you early stabilize, the ARDS also goes less. And another very famous study by Lawrence Bone, who studied that if you do early or delayed stabilization long bone fractures, he said the incidence of ARDS, fat embolism, and pneumonia were less in patients immediate moral stabilization. So we have two schools of thoughts today also who talk about nailing or operating within 24 hours or maximum 36 hours. And then there's another school of thought who wait from second day to the fifth day and take up the patient when he's stable on the sixth or seventh day. This is because of the high intensity of interleukins getting released in the body. So, I mean, that will be another discussion after this. Brundage and all had a good paper they've written that fixation of femur fractures at 2 to 5 days were associated with a significant increase at pulmonary complications, particularly with the concomitant chest or head injury trauma. So he also says that if you do it within 24 hours, do it. Otherwise, you wait for a week before you can take up the patient for nailing. Complications are like literally with every shaft of femur fracture, you can have leg length discrepancies, non-union malignance. You can even have a neurological injury in these patients. To summarize, basically, we don't have to miss concomitant injuries, including neck, femur, or other fractures. IMN intermittent nailing is, I think, so the gold standard for both bilateral sharp femur fractures. Reaming has a good union light. Multiple options we can discuss, antegrade versus retrograde, both can be done, and they have good equal results in these patients, and many complications presented. For bilateral, worse overall prognosis, higher mortality. This is actually because we're not able to resuscitate on time. We're not able to decide should the patient be a candidate for ETC or should be candidate for DCO. You have to calculate the higher ISS score. If you have a higher ISS score and lower GSS score with these bilateral fractures, there is going to be some sort of mortality in these patients. Nail-less comminuted fractures, first to assess length and rotation. And then lastly, it's a relative indication for retrograde nail fixation. Thank you.